handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
So next, we move on to common diseases and health programs. So after the very rigorous discussion for research and biostatistics, we now move on to some the more in-depth clinical discussion on some common diseases, namely TB, rabies, dengue, and some high-yield concepts on each. Okay, so let's start with TB. So I based my discussion on the 2020 Manual of Procedures, and these are the notable policies and changes, the practices that are adopted for the 2020 version of the manual. So systematic screening for TB implemented in all health facilities. So for healthcare workers ito. Symptom screening for any of the 4 cardinal signs and symptoms. So they particularly outlined some cardinal signs and symptoms, namely 2 weeks of cough, unexplained fever, unexplained weight loss, or night sweats. So any of those 4 signs and symptoms can alert someone for screening for TB. So annual screening with chest x-ray in all healthcare workers is recommended. And active case finding for those with diagnostic or clinical suggestions of TB with chest x-ray for initial screening. As we've discussed, kung ano yung screening test, yung high sensitivity, and gene expert or expert for confirmation. Confirmation tests with high specificity. Okay, so this is the basic gist of the 2020 MOP policies. Although there are more, these are the general strokes of the 2020 MOP. Okay, lastly, screen PLHIV, persons living with HIV for TB. So if a patient is diagnosed with HIV at the onset, they will be tested for concurrent TB. Did you know that in other countries, whenever a patient contracts tuberculosis, that is in effect a retroactive search for HIV, because whenever patients there get TB, that only ever means they also have HIV. In the Philippines, however, everyone has TB. So, but not everyone has HIV. So you can't really look for HIV in everyone who has TB. But for everyone with HIV, screening for TB is recommended. Okay, other policies. Again here, this is for the diagnostic algorithm for TB, in particular presumptive TB, not yet the confirmed TB. So any of the 4 cardinal signs that lasts for 2 weeks or more: cough, unexplained fever, weight loss, and night sweats. Yes, that is already clinical grounds for presumptive TB, and you are recommended to get, or the patient is recommended to get, an gene expert, Mycobacterium tuberculosis rifampicin resistance test. Okay, if not, they can go for a chest x-ray, and if they have chest x-ray findings suggestive of TB, yes, here that is also presumptive TB. So either clinical or radiologic evidence of TB, you can go ahead to expert confirmation. If there are neither clinical data or clinical history suggestive TB, nor X-ray findings suggestive TB, then that's a signal to consult or look for other diseases. So there, case finding can be passive or active. Passive means um, the patient or the TB patient comes to the TB dots, for example, for consult. Active means that the TB dot staff will look into high risk clinical groups or high risk areas for active cases. Intensified means there is contact tracing essentially. If there are, in particular, DRTB cases, drug resistant TB cases, then they are backtracked for potential contacts for their TB. And enhanced case finding for a group of people who may have the TB enforce. Highest clinical groups, close contacts, contact tracing, house contacts, as I mentioned. Again, the presumptive diagnosis for TB includes 2 weeks of the aforementioned 4 cardinal signs or chest x-ray findings suggestive of TB. And presumptive EPTB, which is extrapulmonary TB. Signs and symptoms specific to extrapulmonary sites. Extrapulmonary sites. So there's a myriad of different EPTB signs and symptoms as you can study on your own or for the next PLE. So in particular for pediatric patients under 15 years old, the presumptive diagnosis will include unexplained cough or wheezing for 2 weeks, unexplained fever, unexplained weight loss, or failure to thrive. So that's for 15 years old and below. Okay, whenever a person falls under TB presumptive diagnosis, they're candidates for Gene Expert. And Gene Expert is now the diagnostic test of choice, no longer DSSM or direct sputum smear microscopy. Okay, TST is the PPD for the wheel, not generally recommended for confirmatory tests. Sputum collection methods are also outlined in 2020 MOP, how to get them. Now the spot method is accepted. 1 of 2 tests positive for the for the sputum, and 1 hour apart at least. Okay, so for findings of chest x-ray that are suggestive of tuberculosis, hilar lymph nodes, miliary mottling, and apical opacification or cavitation. These are actually what we say are active signs of tuberculosis as can be evidenced on an x-ray. For example, on this x-ray, you can see airspace disease. Airspace disease here, which may be indicative of a form of pneumonia, but because there are enlarged paratracheal and hilar lymph nodes here, that is probably indicative of an active tuberculous infection. Okay, another example here, there is reticulo-hazy opacities in the right apex, so that's apical opacification cavitation. In this particular x-ray, it's kind of blurred, so the opacification or cavitation, the cavitation is not immediately evident, but the apical location is usually typical for TB, even active TB. There's such a thing as fibrotic densities, which are indicative of old TB, on the other hand, in contrast. Okay, and lastly, here, miliary mottling, miliary less than 2 millimeter sized lesions or densities seen all over the lung, which is indicative of miliary tuberculosis. Yeah, miliary mottling. So these are clues for tuberculosis in the chest x-ray or when otherwise suggested diagnosis by the radiologist reading the x-ray. Okay, so next, whenever the diagnosis of TB is given, TB patient classification is done. So there are many ways to classify TB patients, but according to bacteriologic status, we have bacteriologically confirmed and clinically diagnosed. So this is kind of self-explanatory. Whenever a patient is started on treatment for TB based on clinical symptoms only, history, PE, whatnot, they are categorized as clinically diagnosed. Usually, these patients did undergo the tests, but they yield indeterminate or negative results. But despite that, because the clinicians are inclined to qualify them as having TB, then they are also recommended for TB treatment. And of course, bacteriology confirmed expert DSSM sputum exams, when they're positive, they are automatically bacteriologically confirmed. Okay, based on drug resistance, we have monoresistant, polydrug resistant, multi-drug resistant, XDR-TB, and RR-TB. Okay, so monoresistant means they are resistant to just one drug in the drug regimen, the drug armamentarium for tuberculosis. Polydrug, that means they are resistant to two drugs that are not, take note, that are not isoniazid and rifampicin at the same time. Because if they are resistant to both isoniazid and rifampicin, they are now they are now MDR TB, multi-drug resistant TB here. XDR TB, on the other hand, means that they are, in addition to being multi-drug resistant, they are resistant to fluoroquinolones and one of the many injectable drugs given for TB. So that's XDR TB. And RR-TB in particular is rifampicin-resistant TB. Of note, the Gene Expert test inherently will give you the status of rifampicin resistance in cases of positive TB diagnosis, because rifampicin resistance immediately upgrades the patients to have the DRTB regimens, the drug-resistant TB regimens. In particular, the DRTB regimens, which is distinct from your normal HRZE 2-month, 4-month distinctions. The DRTB regimens will not have rifampicin as a drug of use, drug to be given in those TB patients. Okay? So that's the particular caveat for RRTB. That's detectable with Gene Expert. That's also the utility of Gene Expert in the current setting, where it is has a high yield and can immediately give you the status of resistance of the bacilli to rifampicin. Okay? With that said, TB treatment, it's no longer, if you're studied med school at an earlier time, you may have heard of the CAT1, CAT2, CAT1A, CAT2A, all those different types. So now they've renamed the categories into Regimen 1 and Regimen 2. Regimen 1 is the classic 6-month regimen with the 2-month intensive phase and the 4-month maintenance phase. So if you're not aware, HRZE is an acronym for the 4 main drugs used for this is a drug-sensitive TB. HRZE, H stands for isoniazid, R for rifampicin, Z for pyrazinamide, and E for ethambutol. So H again for isoniazid and R for rifampicin. Regimen 1 is same as always, 2 HRZE, 4 HR. And regimen 2 is specific for patients with TB of the CNS, so meningitis, bones, and joints. So these three will require higher, longer durations of the maintenance phase, up to 10 months of maintenance phase for a total of 12, twice that of regimen 1. Okay? So, I guess you also know that for each of the 4 main drugs, there are allotted given weights or given dosages per weight of the patient. What may be more commonly asked or more high yield for the upcoming exam is this, just counting the number of quad tablets to be given per day to the patients, because they're all already calibrated to a certain weight. So 75, 150, 400, 275 is the division for the HRZE. And for a patient, for example, if they're 28 kilograms, and that's very thin, 28 kilograms, they only need 2 tablets per day. If you're 56 kilograms, you drink 4 tablets per day on the corresponding part of the regimen, intensive or continuation, maintenance phase. Next, we go to sort of a loaded table here. It's the management of drug side effects for tuberculosis medications, focusing mainly on the 4 main drugs and the injectable streptomycin. So HRZE again, and S for streptomycin. Here, streptomycin. So for mild side effects. So the distinction of the mild and the major side effects is that in the mild side effects, discontinuation of the drug or the suspect drug is not indicated. So continuation with the TB treatment is done. So let's go through each one by one. So for GI intolerance, which is very, very common, HRZ are the main culprits. Isoniazid, rifampicin, pyrazinamide. The drugs can be given at bedtime, and the patient can take small meals. So in actual practice, in the experience of TB patients, what they do is right before downing the many tablets of TB drugs, they eat a lot, they drink a lot of water, they anticipate the vomiting and the pain. So usually it's up to them, the patients, what their style is. I've seen people eat breakfast immediately before going to TB dots, eating 3 small bananas, eating salads. Some of them don't eat for a few hours before taking the drugs, but it's all for adjusting to their peculiar quirks for GI intolerance. So as long as they're drinking the medications, it's okay to help them. And when the GI intolerance becomes severe or intolerable, that's when it becomes a major side effect. Next, for mild skin reaction, typically any drug can cause a mild skin reaction, and simple antihistamines can suffice. Red-orange urine is classic for rifampicin. The patients can be scared, but they can be reassured it's normal, nothing to worry about. Pain at injection site obviously is for the injectable parenteral drug streptomycin. You give a warm compress after injection, and alternating sites of injection. So left, right, on subsequent inoculations, on subsequent injections. Burning feet or peripheral neuropathy for isoniazid has to do with the glutamic acid decarboxylase mechanism. So what happens is Isoniazid will inhibit glutamic acid decarboxylase, which will produce GABA. So gamma aminobutyric acid, which is an inhibitory neurotransmitter in the CNS. So if there is no GABA, there is excitation of the CNS, which manifests initially as peripheral neuropathy or burning feet, but can, on the other end of the spectrum, can be so severe as to cause grand mal seizures. So at least for burning feet or peripheral neuropathy, when a patient has this symptom, they can be given an additional pyridoxine to counteract the process of isoniazid inhibiting the said enzyme, glutamic acid decarboxylase. So pyridoxine given can stimulate the production of can stimulate normal metabolism of the glutamic acid to become GABA, pyridoxine. Yan. Arthralgia is mainly due to that's Z. Sorry, that's not P. That's Z pyrazinamide. So pwede na rin P pyrazinamide. It's Z pyrazinamide. Aspirin and NSAIDs are given for arthralgia. This is mostly due to the side effect of pyrazinamide to increase uric acid. So pyrazinamide does this by inhibiting a transporter in the renal tubules. That said transporter is supposed to excrete uric acid, but the pyrazinamide inhibits this, so uric acid is retained and some gout-like symptoms are experienced. So arthralgia is the most common side effect from pyrazinamide, but the most severe is still liver hepatotoxicity. Anyway, moving on, flu-like symptoms, mostly from rifampicin and paracetamol is given for flu-like symptoms. Next, for severe skin rashes, any but mostly streptomycin because it's injected. Jaundice and hepatitis, we will discuss this further on later a bit. HRZ, isoniazid rifampicin, and pyrazinamide are the culprits. Blurring of vision and color blindness. Specifically, red-green optic neuritis, dissociation or failure to identify red and green as a form of color blindness, is experienced with ethambutol. So the exact mechanism of the ethambutol side effect for the eye is not yet known, but it's believed to be caused from imbalances in the copper metabolism. There. Tinnitus and hearing loss from streptomycin. More accurately, streptomycin, being one of the aminoglycosides, will have ototoxicity and nephrotoxicity, but streptomycin in particular will have more effects on the balance, the vestibulocochlear aspect. So it's loss of balance, vertigo for streptomycin. Oliguria, albuminuria, namely renal failure from streptomycin, again yung nephrotoxicity and rifampicin. Neurologic symptoms, as I outlined earlier, from one spectrum of peripheral neuropathy, benign peripheral neuropathy, to grand mal seizures, can be experienced with isoniazid, and shock symptoms can be seen with rifampicin. And for all major TB drug side effects, the management is to discontinue the suspect drug and to refer to a specialist. Okay, that's it. It's easy to memorize the management for these. Just know for the exam, for example, they will ask if a patient having these side effects comes to your clinic, what will you do? So the options are give this med, reassure, or discontinue. So you will know what to do given the symptoms and given the potential culprit drugs. Okay? Now for allergic reaction, which we have not yet enumerated in our previous two slides, for allergic reaction, what we do is we give challenge doses for the patient. So what the challenge doses mean is that for 1 day in your in the patient's intensive, or for example intensive phase of treatment, they will first discontinue all four TB drugs. So for the clinician to accurately determine which of the four the patient is specifically allergic to, we will discontinue first and then start by giving the dose of isoniazid, which is the least likely drug to cause an allergic reaction at a low dose. So that's on day 1. Day 1, 50 milligrams isoniazid. If they survive that, if there are no allergic reactions, they can move on to day 2 with a higher dose. And if there's still no allergic reaction, you can go to a full dose on day 3. On the 4th day, so that's day 1, day 2, day 3, Monday, Tuesday, Wednesday. On the Thursday, rifampicin is given at 75. And for example, they get the allergic reaction there. So maybe rifampicin is the culprit. So you adjust the dose to a number which is tolerable for the patient, and you can give the other drugs as needed, or introduce them slowly if you still suspect that there are multiple allergies. Just the whole system of this challenge dosing is to determine which drug is the culprit for the allergic reaction, and at what dose is the maximum tolerable dose for the patient. So you're ascending from least likely to cause a reaction to most likely. So that's isoniazid to rifampicin to pyrazinamide to ethambutol, which is conveniently also HRZE. Okay? There. So next, for the concept of TB management comes TB monitoring. This means how will you monitor the effect of the TB treatment to the patient, whether there is any improvement going on. So to monitor TB, use DSSM, not anymore Gene Expert. So that's for DSSM. All patients under the TB treatment will undergo a direct sputum spear microscopy at the second month, at the end of the second month, or at the end of the intensive phase of treatment. So, if they are clinically diagnosed, if they are positive at that second month, they will proceed to DSSM at 5th and 6th month. If they're positive, if the clinically diagnosed patient has a negative result on the second month, then they're good to go. No more other follow-up monitoring needed. But if they were bacteriologically diagnosed, then they will have to undergo second month, 5th month, and 6th month DSSM to complete. Okay? And that's if they're all negative, so that's just for monitoring. If, for example, they had a positive result at the second month, you request for a gene expert to initially screen for any resistance. If rifampicin resistant, if RR here, you shift them to a DRTB regimen. So that's a whole other animal, yung DRTB regimens. Else, if the expert suggests that there is no resistance, treatment is continued and a culture or a drug susceptibility test is done to determine if there is any other sensitivity or resistance that is not rifampicin in particular. Okay? So if positive at the 5th or 6th month, but earlier, we have 5th and 6th month tests. If, regardless of bacteriologic status, if they are 5th, 6th month positive with DSSM, that is automatically a failure, and they are referred to PMDT for potential resistance. So they will be treated as DRTB or will undergo further tests. Okay, so next for TB is a classic question, not just for the exam, but for the actual patient's infectivity. Nga, Doc, magpapa ako ng TB, kailan po ba ako fit to work talaga? So yung fit to work, maybe institution differences, but theoretically, biologically, if after 1 week of treatment, straight 7 days of TB treatment, the clinically diagnosed patient is already non-infectious to other people. And the bacteriologically confirmed or diagnosed patients, ideally after 2 months of treatment, earliest would be at 2 weeks for them if they really need it. So after 1 week and after 2 weeks are the earliest you can declare that the patient is no longer infective to others. Okay? So, another caveat for tuberculosis monitoring and treatment is, what if the patient left and stopped TB treatment halfway through? What will you do? So you have to determine how long their attrition was, how long were they away first, and whether or not and how far along they are on their treatment, on their 6-month treatment, for example. So if the patient was not there for example, 3 weeks, 3 weeks siyang nawala sa TB dots, di siya bumalik. So you just prolong their treatment from 6 months to 6 months and 3 weeks to compensate. That's all you do. So violet is still good, you're still okay, just prolong. That's the violet cells, table cells. Okay? But for more than 1 month, less than 2 months, let's say 6 weeks, if the patient was gone for 6 weeks, no follow-up, you have to request for a direct sputum smear microscopy. If negative, you just prolong to compensate. So instead of 6 weeks, 6 months, it becomes plus 6 weeks, so that's 7 months and 2 weeks. But if the patient has positive DSSM but has not been treated yet for the duration of 5 months out of the 6-month entire regimen, you just prolong to compensate again. Okay? But if the DSSM is positive and they are already 5 months into the treatment, that is failure of treatment already. And if the patient has been lost for more than 2 months, has been gone for more than 2 months, that is already classified as lost to follow-up. So next, for DRTB, as I have alluded to earlier, so drug-resistant TB, usually treatment will last anywhere between 9 to 20 months, an extension from the normal 6 months in the DSTB or the drug-sensitive TB. LPA tests are done, lung probe assay, and the drugs involved are as follows: levofloxacin, bedaquiline, clofazimine, prothionamide, ethambutol again, pyrazinamide again, yung Z, high-dose isoniazid, so that's HDH, it's still isoniazid, dilamanid, cycloserine, and linezolid. So notice how there is no rifampicin anymore. So any DRTB regimen will not include rifampicin. So in particular, the specific regimens are different. There are many varieties for DRTB regimens and will include different mixes and different durations of the following drugs. For example, there's the SSOR standard short oral regimen for 9 months. So 4 tsaka 5 months yung hatian niya. In qualifying patients for SSOR, there's such a thing called as exclusion criteria, wherein if the patient will have any exclusion criteria for them, they will no longer be candidates for SSOR regimen for TB treatment. So this includes multiple heart conditions, disseminated TB, resistance to any fluoroquinolone. So those will automatically exclude the patient from receiving an SSOR. So these are just usually checklists for potential adverse reactions to the many drugs listed here. So again, if there's any question saying, okay, which of the following drugs are not given for DRTB, that's most likely rifampicin, because it's not given for DRTB patients anymore. And add to that, remember, rifampicin is being tested for resistance in the usual gene expert. Okay? So now we go on to some special situations for the treatment of TB. So what are some other peculiar clinical situations where there need to be adjustments in how TB is being treated? First off, for pregnancy, what happens with a pregnant patient with TB? So rifapentins are avoided for potential adverse effects. Streptomycin is contraindicated for ototoxicity to the baby. And pyridoxine 25 milligrams per day is given as a supplementary vitamin for the pregnant patient. For patients taking oral contraceptives, one caveat to note is rifampicin stimulates hepatic metabolism. Therefore, this will cause the depletion and metabolism of the estrogen component of the OCP. So a higher dose of the OCP, particularly the estrogen, is needed to maintain the contraceptive effect of the OCP being taken. Okay? Or alternatively, other forms of contraception can be advised: IUD, condom, others that will not rely on systemic hormonal levels, because these can be affected by the rifampicin intake. Okay, acute liver disease, take note, acute liver disease, hepatitis, and the like, elevated liver function tests. If the ALT in particular is 3 times above upper limit of normal and the patient is symptomatic, that is an indication to discontinue the TB treatment. Or if the ALT is elevated 5 times of the upper limit of normal, regardless of symptoms. And the least hepatotoxic to most hepatotoxic are listed as follows: RHEZ. So this is the most hepatotoxic, yung pyrazinamide. Special situations, again, chronic liver disease, pyrazinamide being the most hepatotoxic, is not given for patients with chronic liver disease, kunwari cirrhotic, and they can have adjustments in their TB regimens to SHRE, 6HR, the 8-month regimen, 9RE, and 2SHE, 10HE. So notice the trend here. The shorter the regimen, the more drugs given here, and the longer the regimen, the lesser drugs given. And notice how there is no pyrazinamide being given for patients with chronic liver disease. For renal disease, isoniazid and rifampicin are not adjusted. They are excreted renally but are metabolized hepatically. But on the other hand, pyrazinamide, ethambutol, and streptomycin are adjusted whenever a patient has renal disease, elevated creatinine, suggesting any form of renal parenchymal disorder. Okay, HIV. So typically, you want to treat TB before HIV because treating TB, the bacilli first will help. Because if you treat HIV first, you're reactivating the immune system of the patient that will potentially aggravate the status of the TB. That's basically it. There's a whole lot of mechanism there, a whole lot of pathophysiology, but that's really what you need to think about. If you're treating HIV first, you're reigniting, reviving the patient's immune system, and this will complicate further the incumbent tuberculosis in the lungs. So one option is to finish the outright 6 months of TB before undergoing antiretroviral treatment. So this is ideal, but not all patients clinically will have the luxury to undergo this type of management. because the HIV threat can already overshadow anything else. So if they're at the threat of dying from HIV complications, one option is to first undergo a shorter, intensive 2-month HRZE regimen, followed by antiretroviral therapy and a continuation of ethambutol and isoniazid instead of rifampicin. Okay, but if you really need to concomitantly treat both TB and HIV, the regimen is as follows. You use efavirenz plus 2 NRTIs in whatever ART you are going to use, and adjust the TB drugs based on what you need for the patient. So efavirenz plus 2 NRTIs are needed. Reverse transcriptase inhibitors. Okay. So now we move on to our next topic on rabies. Particularly for rabies, we will see some microbiology, the basic management, family community medicine related topics for rabies, vaccination, must-knows about vaccination, do's and don'ts for management of rabies, and the like. So let's start. Rabies is caused by the lyso virus, the rhabdovirus. So it's a ssRNA, single-strand RNA. I think it's negative sense and envelope. So these kinds of classifications for the viruses being single-stranded, double-stranded, RNA, DNA. Positive, negative sense, envelope, non-envelope. These may be some concepts or things that you might have to remember when you're near taking the exam, because these are potentially easy points for you to get provided you memorize the table. So at least for now, you can remember rabies as ssRNA. So just a bonus tip, a very common question that they will ask is which DNA virus is single-stranded and which RNA virus is double-stranded. Those are some of the common easy questions that they might ask or are being asked everywhere, not just the PLE. So again, back to rabies, ssRNA cannot cross intact skin. So this means that the vector for transmission of rabies, or not the vector, the method of transmission of rabies requires that intact skin be violated. So if it's just saliva, sweat, or whatever fluid that comes in contact to you, the person, the patient, but intact skin has not been violated, then rabies cannot be transmitted, theoretically. Okay, so rabies as a disease is 100% fatal when complicated, when the virus takes its toll, rabies disease takes its toll, but on the other hand is also 100% preventable provided vaccination is given at a timely and appropriate manner. Okay, so even though it's 100% fatal and 100% preventable, or it's 100% fatal, it is 100% preventable. So I guess it's a familiar concept to you in med school that whenever a patient with rabies has already reached the furious phase where they have aerophobia and hydrophobia, they're already sentenced to death. And I think across history, only a couple of patients have survived the full-blown rabies infection. So it's, again, 100% fatal. So I want you to look at this picture here on the right side. As I mentioned before, ssRNA siya, but under rhabdoviruses, one peculiar characteristic of this virus is that it is bullet-shaped. Ayan. So ssRNA envelope, spike G protein, and the characteristic bullet shape. I think it's the only virus with this characteristic, bullet shape, rabies. Okay, moving on. Another common question is, of course, you can get rabies from dogs and cats, but one common scenario question that they ask is, what if you're bitten by this blank animal, whatever animal, a rat, for example? Will you treat the patient, or the patient being bitten by rats or mice? Do they need to have rabies vaccination? So, so you can't get rabies from the following animals: rats, rabbits, rodents, reptiles, and birds. Meron pa ba? Yan, you can't get rabies from blood or feces as a method of transmission. So, if a question prompt asks whether or not you need rabies vaccination, rabies prophylaxis for rat bites, rabbit bites, rodent bites, reptile bites, bird bites, you won't need rabies vaccination. So those are the animals that will not require rabies vaccination. If you don't see an animal listed here, then if you're bitten by that animal, you might need rabies vaccination, as we will see later on. Okay, so moving on, we now discuss the phases of the rabies disease, the natural history of the rabies disease. So there are 5 in particular, and the progression of these 5 depends upon whether or not appropriate vaccination was given at the appropriate time. So the first is incubation period. Ayan, 1. In this period, it may last anywhere from 5 days to 2 years. The virus crosses the myoneural junction, and patients are generally asymptomatic. And this is the only time wherein vaccination is effective. So you might ask, yeah, Doc, why is the incubation period so long? Why is the range for the incubation period so long? As short as 5 days and as long as 2 years, as opposed to many infectious diseases that have a very predictable incubation period. So the explanation for this is the incubation period for the disease to set in generally depends on where a person is bitten. So, for example, how do you compare a person bitten on the foot, on his or her foot, versus a person bitten on their face? This matters because the method of rabies transmission, or the method of rabies travel inside the body, depends on this so-called crossing of the myoneural junction. So from the muscles, muscle fiber, muscle tissues, going through the junction to cross into neural tissue. The end goal, I guess, of the rabies virus is to get to the central axis of the body. So to penetrate the central nervous system. So whenever a bite site is closer to the CNS, the incubation period effectively is reduced in duration, as opposed to when the bite site is far from the central nervous system. So that's why we have a wide range of incubation period from 5 days to 2 years. And how long will it take for the virus to traverse the tissues from the periphery to the center to eventually enact the classic rabies symptoms that you know? Okay, and in this stage, the patients are asymptomatic, and again, it's the only time wherein vaccination is effective. So whenever a patient goes into the latter phases, the second phase and the latter phases of the rabies infection, vaccination is attenuated in effectivity, and in the late stages, and vaccination is almost useless at that point. So this is why rabies vaccination is critical, because if you're able to catch the patient in the incubation period, generally, your most kind of fail-safe duration is within the first 5 days. Then you can save them from any kind of fatal rabies infection. So in my experience is, I've had patients ask me, "Ngayon, Doc, maliit lang naman yung kagat ng aso. So baka hindi na kailangan ng rabies vaccine." So kunwari kinagat lang sa daliri, bitten in on the finger from feeding snacks, Scooby-Doo snacks or whatever, and the dog accidentally bit through the finger. So they would ask, is rabies vaccination still indicated when the wound is very small? So you have to explain to them that the size of the bite site, or the severity, or the range, the diameter of the bite site does not really matter in the grand scheme of the virus crossing the myoneural junction. So I explained to them, as long as there is a bite site that qualifies as category 3, as we will see later, a bite site that qualifies as category 3, then regardless of whether or not the bite site is large, then that we already have a potential pathway for the rabies virus to traverse the body to end up in the central nervous system. So that's why even small bites can be deserve proper vaccination. What more pa yung mga big bites that will have large amounts of inoculation potentially of the rabies virus. Okay, so that's enough of incubation period. Next, 5 stages pala. So we now go to the prodrome phase. So after how many days or years long of the incubation period, we go to the prodrome phase, which lasts for 10 days and manifests as fever and malaise, which are typical of a systemic viral infection or any systemic viral infection. So one particular symptom that patients experience, can potentially experience, is paresthesia on the bite site because of ganglioneuritis, which means the rabies virus, has already reached the central nervous system, specifically the DRG, or the dorsal root ganglion. So paresthesia, or the tingly feeling at the bite site, is the first rabies specific symptom that patients may experience. So I guess some anatomic correlates first before going forward. What is the DRG again? So yes, I'm sure you've heard of the dorsal root ganglion before in your anatomy lectures. So I'll just do some quick annotation, drawing of the spine, I guess. So this is a cross section of the spinal cord and yung spinal cord. From the spinal cord, we get, kunwari dito sa right side, parang MRI, CT scan. Yan. The right side, this is the spinal cord, white matter, gray matter, whatever. May H dyan. This is the, let's say this is the dorsal root ganglion. So these are roots, the posterior and the anterior root. So this is anterior root. When these two combine, that's the nerve. Let's say this is at the level of T7. So this is the T7 nerve. And from the T7 nerve, you can get the anterior branch and the posterior branch, the somatic anterior branch, and the posterior branch for the back and the thoracic wall, for example, for T7. So don't confuse the roots, the nerves, the ganglia, the spinal cord. That's what you need to remember. So another name for these branches at branching off from the nerve are the ramos, singular, rami. So again, these are already parts of the central nervous system, or at least approaching the central nervous system. So whenever infiltration of the DRG by the virus has already occurred, then that is already a prodrome phase. So ganglioneuritis occurs because the DRG, the posterior root, is mainly responsible for somatic sensation. So because I guess the rabies virus travels through a highway of nerves and will most likely end up here first, then that is the manifestation of the symptomatic manifestation of the rabies virus, which is ganglioneuritis paresthesia. Okay, so the third phase is the acute neurologic phase, which involves the classic symptoms. So this lasts for 2 to 7 days only. There is respread of the rabies virus to peripheral organs, and it can be divided into either an encephalitic or a paralytic type. So the encephalitic type is what you typically observe from patients with hydrophobia, aerophobia. Basically, the list of symptoms boils down to whatever you see from a rabid dog, you also see in a rabid human or a rabid patient. This is in contrast to the paralytic form, wherein mainly the patients have a course of decreased sensorium and coma eventually. I would like to point out a particular symptom called percussion myoedema for the paralytic type. So this occurs because of hypotonia of the muscles. So what is percussion myoedema? So percussion myoedema occurs, this is a physical examination finding wherein slight stimulation of the area of the biceps, slight skin stimulation will result in mounding of the muscle to form a small kind of bulk on that area. So that's percussion myoedema. You can look for a YouTube video of that. Go ahead, pause this video, look for a video of percussion myoedema. It's also seen in hypothyroidism, I guess another form of another manifestation for hypotonia. And this is also a specific symptom for this specific type of rabies. So again, kanina, yung ganglioneuritis, paresthesia, and percussion myoedema. Okay, so those are maybe some symptoms in rabies that you have not encountered before, because I believe, confident naman ako na for the other symptoms, you already know how to differentiate encephalitic and paralytic rabies. Okay, next, for the last two stages, coma for 5 to 14 days because of general spread and the poor prognosis of rabid patients, and eventually death. So yeah, those are the five stages: incubation, prodrome, acute neurologic, coma, and death. There. So moving on to some diagnostic correlates for rabies, the ante-mortem lab diagnosis. So because unfortunately because you're expecting the patient to die when they exhibit rabid symptoms, we term the lab diagnostic tests as ante-mortem, before death. So yeah, there, FAT, PCR, RFFIT, and histopathologic findings of Negri bodies. So FAT stands for fluorescent antibody testing. This is the gold standard for antemortem lab diagnosis. You use tissue samples from central nervous system structures, namely the brainstem, thalamus, cerebellum, and hippocampus, wherever biopsy is feasible. And you may also use nuchal skin biopsies, neck sa batok, or hair follicles in the nuchal area. Serology can also be used. Yun yung here, RFFIT, which stands for Rapid Serum Rapid Fluorescent Focus Inhibition. So these are just basically serum neutralization assays. Fancy, sort of similar to ELISA antigen antibody assays neutralization. So you just take a serum sample from the patient, you mix it with wells with antibodies, and if there is a reaction, it can be quantified. Yeah, that's a bare bones, very bare bones explanation for what it is. It's basically just a serum neutralization assay. PCR, of course, serum sample to get or tissue sample to get the antigen specific for rabies. Lastly, histopathologic correlation with the classic finding of Negri bodies. So, Negri bodies shown here on the right hand side. Negri bodies represent intracytoplasmic, eosinophilic, oval inclusion bodies, as can be seen here. And these are usually seen in tissue samples taken from the pyramidal neurons of the hippocampus and the Purkinje cells of the cerebellum. So these are the particular sites for biopsy because they generally have no inflammation. So they have high yield for the Negri bodies, because in other areas wherein inflammation may be widespread, the tissues themselves may just have granulation, have repair, have weird morphologies and histopathologic findings. Maybe not yielding the classic Negri bodies. Okay. Other methods include ultrastructural immunohistochemical studies, which we'll not discuss further, I guess. So moving on to the PEP, or what we call the post-exposure prophylaxis. So that is what the acronym PEP stands for. This is in contrast to PREP or PrEP, which is the pre-exposure prophylaxis. So be very careful when studying PEP and PrEP, as you have to differentiate between the two. And for questions, obviously, questions in the exam, whether or not you're dealing with post or pre-exposure prophylaxis. In this case, exposure means the bite of the rabid dog, for example. So that's what the exposure is. That's the most common, although there are other forms of exposure as we will outline later. So for PEP, or post-exposure prophylaxis, which is the more common, I would say, clinical route by which we will encounter patients. So mostly they will already come to the clinic, the animal bite treatment center, or the ER, having already been bitten. So that's for PEP, post-exposure prophylaxis. So I will divide the discussion for post-exposure prophylaxis into 1, local wound care, and 2, immunization. So first, for local wound care, generally the first steps to undertake are to just wash the wound with soap and water. Any clean soap, clean water, preferably yung sterile, NS kung meron, for 10 minutes. Although kung wala sa clinic setting, just at the house, tinawagan ka, pwede na rin yung basta dapat clean talaga. And okay yung soap for 10 minutes just to wash the wound. And products such as alcohol and betadine are allowed, But ointments and creams, for example, are not recommended for rabies for wound bites that potentially have rabies because bite wounds that potentially have rabies, because this will favor bacterial infection and secondarily um, the viral inoculation. Dressings as well, pressure dressings, for example, also will just help viral inoculation. That said, is suturing allowed for bite wounds that potentially have rabies? So if that's just the question, suturing, pwede ba i-suture yung mga kagat? The answer is no, because similar to dressing, suturing will favor further inoculation of the virus into the bodily tissue, the muscle tissue. But in cases wherein the bite site is very deep and bleeding needs to be stopped, massive bleeding needs to be stopped, and hemostasis must be achieved, then suturing may be done. Preferably first try yung mga staple the adhesive tapes first before doing any suturing. If not, if suturing really is required, yung mga simple interrupted sutures, kunwari, for example, then the rabies immunoglobulin, yung RIG, the passive form of immunization, must already have been administered into the bite site, the bite wound, before suturing is undertaken. So that's the caveat for suturing. Can you do suturing? If that's just the question, then you say no, but it depends, right? So that's for local wound care. Okay, next, under post-exposure prophylaxis, still under wound care, sort of, is antibiotics. So all category 3 bites, as we will discuss later, will require administration of antibiotics, and any joint penetration also warrants antibiotic use. Immunocompromised patients also need antibiotics, and grossly infected wounds also need antibiotics. So remember, obviously, you're not giving the antibiotics for the rabies virus. It's for the superimposed or the potential for bacterial infection. And what antibiotics do you give? If there at the onset, if there are no signs of infection, the amoxicillin regimen is given, and if infected, you give coamoxiclab, cefuroxime, or clindamycin. That's it. So now we go on to the classification of rabies exposure. So rabies exposure can be categorized into 1, 2, or 3, depending on the severity of the bite, and the categorization will subsequently instruct you on whether or not rabies vaccine and rabies immune globulin is indicated. So before I dive into the table, remember first that rabies vaccine here is a form of active immunization, meaning you are inducing the patient's body to produce their own form of immunization against rabies, as opposed to RIG. It's passive immunization because you're explicitly giving the antibodies, the immunoglobulins, to fight off the infection, to fight off the rabies virus in vivo. So this is active and this is passive. So let's go. Category 1, cat 1, feeding or touching potentially rabid dog, cat, whatever, or licking of intact skin. So remember our caveat earlier. Theoretically, the rabies virus cannot cross intact skin. So if ever there is only feeding or touching or only licking of intact skin, you have no risk of contracting rabies. So you don't need rabies vaccine and you don't need rabies immune globulin. Okay? For category 2, you have superficial scratches without bleed or only induced to bleed, or nibbling of skin regardless of bruise or hematoma formation later on. So whenever this is the situation being faced, rabies vaccine is indicated, but the situation is not so severe that rabies immunoglobulin is also indicated. So yes and no. And for all else, category 3, the most severe category, whenever there are transdermal bites, evidently these will bleed, spontaneous bleeding as well. So iba yung induced to bleed and spontaneous bleeding, leaking of mucous membranes, broken skin, exposure to any meat carcass of the dead dog, for example, or the infected meat. So this happens in some places wherein a rabid dog is killed and is eaten afterwards as a meal, I guess. So that's exposure of the chefs. Kung sino nagluto nung pinatay na aso. That is exposure to the meat carcass and the infected meat that already qualifies as a category 3 exposure. And again, lastly here, any category 2 exposure, any category 2 type exposure in the head and neck automatically qualifies as category 3. Remember our rationale earlier wherein bites nearer to the central axis, the central nervous system of the body, will allow shorter travel of the rabies virus to the brain, the spinal cord. So when a category 2 exposure is found or is located in the head and neck, that is immediately upgraded to category 3. So in category 3, you give both the rabies vaccine and the rabies immunoglobulin. So next, after local wound care and antibiotics, and after considering whether or not the vaccine and the immunoglobulin are indicated, we now discuss the specifics for the vaccine and the IG itself, themselves. So the rabies vaccine is given either intramuscularly or intradermally. So the doses for each will vary, as we will see later on. For intradermal injections, you need to achieve a 3mm wheal, and it is always given either in the deltoid or the thigh for the intramuscular administration, never the gluteus muscles or in the butt. So the rationale for this is purely from efficacy. The rabies vaccine has been found to be more efficacious when given in the deltoid area and in the thigh area. So that's it. That's basically it. Rabies vaccine, again, as I alluded to earlier, there is an existing IM and ID administration route, and the doses will vary. For any intradermal dose, you will give 0.1 ml, similar to other intradermal vaccines that you need to produce a wheal with. So parang BCG, for example. So yung mga yung wheel, yeah. So if you've ever done that or performed vaccination that will involve wheel formation, you will know that you always really just need a small amount. And the PVRV IM and the PCECV IM intramuscular. So these are the brand names, Rabipur and Verorab. So for the PVRV, it's 0.5 milliliters, and PCECV 1 milliliter. So one sort of mnemonic you can use for this is PVRV is shorter, so it needs a smaller dose, smaller amount, smaller volume, while the PCECV is a bigger word, so it needs more volume, 1 milliliter. Okay, that's it. Rabies vaccine. Generally, the schedules on which days the rabies vaccines are given are dependent on the recommended regimen for the area and the available brands. But generally, the days on which the vaccines are given fall under these 0, 0, 3, 7, 14, 28, or 30. So there are some 3-dose schedules, there are some 4-day schedules. The most popular, I guess, or the most commonly taught schedule regimen is one that involves 5 days. So all 5 of these, 0, 3, 7, 14, and an end of the month dosage. So yeah, it will always vary based on what you're giving the patient. Okay, so last dose, particularly the 28th or 30th day dose, is given only if there is laboratory proven rabies, as we've discussed earlier. The animal becomes symptomatic, which is to say that the animal is exhibiting rabid symptoms. If the animal dies or is not tested within the given time frame of the vaccination, or if the animal cannot be observed in the same time frame. So this is because all of these latter conditions means you cannot ascertain whether or not the animal truly has rabies. So might as well give the last dose if any of these conditions are met. So rabies immunoglobulin indicated only for category 3. They are in the form of the human RIG and the equine RIG. So the human serum, the equine serum from horses. One major difference of these two is that the equine, the horse, the horse serum RIG, is subject to more allergic reactions, but is typically better as an immune globulin at providing passive immunization. This third one, the FAB apostrophe 2 with the parenthesis, this is just a formulation of the immune globulin after digestion with papain and pepsin. So it's not really widely used, only these two, HRIG, ERIG. Okay, they are given on the same day as day 0 for the vaccine. So on the day that you give the first dose of the rabies vaccine, day 0, you also want to give the rabies immune globulin. If RIG is not yet available immediately on that same day, this may still be given within the first 7 days of the schedule that you're giving. So, pwede pa hanggang yung third dose, theoretically. So, you might ask, when do we count day 0? So, day 0, for vaccination with the rabies vaccine here, day 0, do we count that as the day the patient was bitten, or do we count that as the day when the first dose is given? So typically, yes, the correct answer there is we count day 0 from the day that they first come into the clinic. So regardless of when the person was bitten, even if they were bitten 2 weeks ago, we still count it as if they were bitten on the day of consult. So that's when you start day 0. Okay, so that's where you count the day 0, day 3, day 7, day 14, day 28, day 30. Well, yeah, that's basically it. And with respect to rabies immune globulin, why can't we give RIG after 7 days of the rabies vaccine? Bakit hindi na pwede kapag more than 1 week na nagbibigay nung primary rabies vaccine? It's because the rabies immunoglobulin is already not indicated at this point because you've already induced the natural immunization of the patient via the active immunization. So at that point in time, na 7 days na nakalipas, you already have immunoglobulins in the circulation, and adding the H-rig or E-rig will no longer be particularly helpful for the patient. Medyo useless na talaga siya. Yun lang naman yun. Next, for rabies, still under rabies, what if the patient asks you, well, doc, bakunado naman po yung asong kumagat sa akin. Kailangan ko po talaga ng rabies vaccine. So what if the dog that bit you, the dog that bit you, that bit the patient is vaccinated? What do you say? So immunization with the rabies vaccine can be delayed if all are satisfied. So before we go into the conditions, note here that immunization is only being delayed because you're still trying to observe whether or not the dog will develop symptoms. So the general plan is, if you can allow the patient to delay immunization because the dog is vaccinated, the general plan is to wait for 2 weeks to see if the dog is still healthy afterwards. So let's see the conditions right now. So immunization can be delayed if all are satisfied. So take note, if all are satisfied, the dog was vaccinated within the last 2 years, the dog can be monitored for 14 days, obviously. The dog is at least 1.5 years old, and the bite is only category 1 or 2 bite. So if you fulfill all of these conditions, then you can advise the patient that yes, we can delay immunization for you, the human being, and wait for 14 days. If after 14 days the dog is still alive, you've seen the dog for 14 days, you've monitored his or her condition, the dog's condition, and he does not develop any curious, peculiar symptoms that may be suggestive of rabies, then yes, immunization is no longer needed. Take note that for any category 3 bite, regardless of the dog's vaccination status, the human that was bitten needs to be vaccinated. Okay, so yes, generally the dog vaccination works for the dog, but if the dog bites you, then that's no guarantee for you as a human. Okay, that's the message to be taken here, and that's what you have to explain to patients who come in after a bite wound. Also on rabies, we now discuss the PrEP or the pre-exposure prophylaxis for people who are expecting to have potential exposures to rabies. So this may be in the form of people who handle dogs, people who research rabies. Basically, those people who have potential to exposure to rabies. Even before they are bitten, they can receive the so-called PrEP or pre-exposure prophylaxis. This involves a 3-dose regimen only, involving day 0, 7, and 28 of either the IMR-ID or the PCECV or PVRV regimen. So after receiving these 3 doses, they are considered previously immunized persons. So if you are previously immunized, you either had the PrEP or you've had a post-exposure prophylaxis of 3 doses at days 0, 3, and 7. That is what you call a previously immunized person. So if you're, for example, a dog handler and you receive the PrEP, you are a previously immunized person. If you are a random person bitten by a dog, you received the rabies vaccine, you followed the day 0, day 3, and day 7 vaccination, but the dog was healthy, or you discontinued vaccination, di mo tinapos yung 5-day regimen, then you're already considered a previously immunized person. If you've only received day 0 and day 3, then that's basically useless in the context of being a previously immunized person. So that is what it takes to become a PIP, previously immunized person. So what is the privilege of being a previously immunized person? You can give a booster shot for a day 0, day 3 schedule whenever an exposure uh, occurs, or whenever you're bitten by a dog, basically. Instead of undergoing the full regimen, receiving the RIG, you can just receive a day 0 and day 3 booster shot, and that's good as full immunization. No need for RIG, because essentially it's also again useless. You already have the antibodies inherent, and passive immunization will be of no help at all. Okay, that's it for rabies. So for our next topic, after TB and rabies under the common diseases spectrum, we now proceed to dengue. So quick insect fact number 10, a mosquito can fly but a fly cannot mosquito. For epidemiology of dengue, it occurs at a rate incidence 50 million per year, and 2.5 billion people in dengue endemic areas. So 2.5 billion people are at risk for dengue if not protected from mosquito bites. 1.8 billion of those 2.5 billion live in Southeast Asia or the West Pacific. Philippines is in Southeast Asia. And for the Philippines, dengue is now a year-round disease, no longer just occurring in some specific months or rainy months or whatever. We are always at risk for dengue if we are not protected. Okay, dengue as a virus is a flavivirus ssRNA again, and it has 4 serotypes named DEN1, DEN2, DEN3, DEN4. So other flaviviruses include West Nile virus, yellow fever virus, Zika virus, and Japanese encephalitis virus. So they are all under the flavivirus genus. So infection with one serotype of dengue, for example, DEN1, gives you immunity to that serotype, but for that serotype only. Secondary infection with a different serotype will predispose a patient to severe infection. So this is what occurs in cases of hemorrhagic shock or DSS, dengue shock syndrome, wherein there is an amplified response to the different dengue serotype, and therefore complicating the initial infection. So it's not surprising, for example, to find people in the Philippines who have immunity to all 4 dengue serotypes, even without experiencing the so-called severe dengue, because sometimes dengue will go unnoticed, quote unquote unnoticed, dismissed as normal febrile, not normal, a usual febrile illness. So that's just some caveat for the dengue disease. So we go right ahead to diagnosing dengue. The diagnosis clinically involves any patient living in a dengue endemic area, which is another way of saying the entire Philippines. So that's one criteria. Fever, a second criteria, and the third criteria, fulfilling any of the 2 following symptoms or lab results: nausea and vomiting, rash, aches and pains, positive tourniquet test, leukopenia or low white blood cell count, any warning signs as we will outline later, presumptive diagnosis positive with either NS1 test or IgM, and if clinical diagnosis is not achieved, then viral culture may be attempted with PCR as another option. So these are virus isolation techniques. So the tourniquet test or the Rumpel lead capillary test involves placing a tourniquet above the antecubital area. So similar to taking blood pressure, mag-inflate ka ng BP cuff there, and you will observe for formation of petechiae in the antecubital area. So, for example, here, kay Renaissance dude, so mali yung tourniquet niya dito sa forearm because you have to tourniquet here. So, you tourniquet there for 5 minutes, and after 5 minutes, if there is a formation of 20 petechial lesions in a 1 by 1 inch area, that is considered a positive tourniquet test. And this is evidence of deranged bleeding parameters because of the affectation of the platelets in the dengue disease process. As a side note, because we're talking about tourniquets and because we've shared this meme here, if you have bleeding anywhere below the antecubital area from the forearm to the tip of your fingers and you want to tourniquet, generally pressure at the area is better than tourniquet. But if you need to tourniquet, the tourniquet has to be above the elbow because if you remember anatomy, the brachial artery courses through the upper arm and will branch right at the elbow into the radial and ulnar artery to supply the radial and the ulnar sides of the arm. And there are multiple anastomotic connections, anastomotic connections between the radius and the ulna, such that, for example, whenever there is a laceration of the radial artery, the carpal arch, the other parts of the hand blood supply, particularly from the ulnar artery, can secondarily supply the other parts that were originally supplied by the radial artery. So if you want to stop bleeding, for example, from a radial artery, because there is collateral supply from either branch of the ulnar or the radial artery, you have to clamp at the origin the brachial artery. So that's just a segue. That's why you need to tourniquet at the brachial artery. Yun lang. Flex lang. Konti. Anyway, moving on. Back to topic. Dengue diagnosis. You can also classify patients based on the method of their diagnosis. So, suspect if we've arrived at the diagnosis of dengue via clinical parameters. Probable if they have positive NS1 or IgM or a CBC result that is indicative of dengue. In particular, a CBC result indicative of dengue means there is leukopenia, progressive decrease in the total white blood cell count. So that is what qualifies under leukopenia. There's a trend of progressive decrease in the WBC. Also, there is a decrease in the platelet count or thrombocytopenia. And another clue is an increase in hematocrit. So these changes may not occur all at the same time. Leukopenia occurs throughout. Thrombocytopenia occurs mostly in the critical phase. And of course, the increase in hematocrit also occurs mostly, evidently, in the critical phase. So I've mentioned the critical phase. We'll go through each phase of dengue later on. And lastly, if there are suspect probable cases of dengue, there's also the confirmed. So that's PCR confirmed, culture confirmed, LAMP. These are all methods of isolating the virus itself. So with virus isolation techniques. So mga very high-tech tests na yan. So to differentiate the commonly used tests to diagnose dengue, laboratory tests. So as I mentioned earlier, may PCR, may LAMP, may isolation, may culture. These are all very advanced techniques, advanced tests that are mostly used for research. And by the time na meron ka ng culture result or PCR result of the dengue, for the dengue patient, their disease course has already is already over. Kasi maghintay ka pa 2 weeks for viral culture or however long, tapos na yung dengue ng patient. So, for practical uses in clinical settings, we use the NS1 and IgM. And IgG, for example, I've mentioned the PCR as a reference. So, let's go through each one by one. NS1. NS1 glycoprotein is detected in the NS1 antigen test. So, NS1 is an antigen test. The NS1 glycoprotein is not inherent to the dengue virus. It is released by infected cells. So, they can be detected on day 1 until day 6 of the dengue infection. Okay, RT-PCR, polymerase chain reaction, real-time polymerase chain reaction, detects viral RNA. And PCR levels, the quantitative levels, coincide with the period of viremia. If there is a lot of the virus in the bloodstream, then the PCR yield is higher, better, stronger, faster. So it coincides with the period of viremia. As long as there are viruses to be seen in the blood, PCR will detect them and will be able to quantify them. IgM, a marker of recent infection, and IgG, a marker of past infection. Particularly, IgG will be positive with fourfold elevation in the as compared to the initial in the convalescence. Initial compared to the convalescence. So for IgM, as early as the 3rd day of dengue infection, you can detect IgM, and IgM will be elevated up until 8 to 12 weeks. On the other hand, IgG is first detected 2 weeks after the primary infection. So whenever IgG is positive, you can definitively say that the dengue infection has happened at least 2 weeks ago. You can't really presume what point in time. You just have to correlate clinically. So it can be 2 years ago, it can be 2 weeks ago. You just have to correlate clinically. And it is detectable forever. It's inherent to your body once you have IgG. Okay. So, dengue phases. We have the first phase, the clinical phases of dengue. Febrile phase occurs in the first 2 to 7 days, manifested with facial flushing, erythema, body aches, myalgia, arthralgia, and headache. In addition to sore throat, injected pharynx, conjunctival injection, anorexia, and the PE findings include petechiae and mucosal membrane bleed as manifestations of thrombocytopenia, low platelet count, mild hemorrhagic manifestations are seen. In the CBCs, as I have mentioned, there is progressive decrease in the total WBC count, leukopenia, with or without thrombocytopenia in this phase. Okay, and symptoms that you can expect that may be severe. The things to really watch out for are dehydration, high fever, and in children in particular, this high fever can lead to febrile seizures. So, one thing you have to learn in relation to dengue and in clinical applications of dengue is the relationship between the signs and symptoms of the patient, the PE findings, the monitoring of the patient, their fluid status, and the current phase in which they are in. So, of course, there are some clues to guide you as to identify which phase a patient is in. Kunwari, yan, first 2 to 7 days. That's just a ballpark estimation. So you can't really say for sure with just counting the number of days. You have to correlate symptoms, PE findings, monitoring, and fluid status with the CBC, laboratories, etc. Because this is important because at different phases of the disease process, there are different major complications that clinicians have to watch out for. In particular, for the febrile phase, yun nga, yung high fever and febrile seizures. Obviously, in the febrile phase, that is when you will expect the temperature to be high, and complications from this high temperature are to be expected or not expected, I guess watched out for or anticipated at least. And because you're anticipating different major complications, you will also have to adjust your treatment based on the specific phase that you are in, as we will explore later on. So, next phase of dengue will include the critical phase, so called because critical complications can occur here, and most deaths from dengue shock, severe dengue, hemorrhagic syndrome can occur here. So occurs on day 3 to 7. Temperature drops, no longer febrile, just a bit high at 37.5, 38 degrees Celsius. And a hallmark for the critical phase is the increase in hematocrit. Increase in hematocrit occurs because there is increased capillary permeability across the body, which allows the fluid to permeate through into interstitial spaces and into third spaces. Because the fluid goes out of the blood vessels, the blood cells are retained inside the blood vessels, and this leads to an increase in hematocrit. Because remember, hematocrit is just a percent. What percent of the blood volume vessel consists of red blood cells? That's the hematocrit. So the higher the increase in hematocrit, the higher the degree of plasma leakage, and therefore the more severe the disease. So the period of clinically significant and potentially life-threatening plasma leakage occurs over a very short 24 to 48 hour period. So yeah, it's where most complications will be expected. Again, third spacing, dahil nag-leak out yung fluid, that is expected to manifest when severe, expected to manifest as pleural effusion in the lungs and ascites in the abdomen. So that's for the pleural cavity and for the peritoneal cavity. Shock eventually occurs kapag marami na nag-leak out. Shock occurs when massive amounts of plasma leak and temperature. Plasma leak occurs and temperatures of the patient may drop to subnormal even. Parang shocking na talaga siya. So we go now to warning signs under critical phase. What symptoms and signs can alarm a clinician as to whether or not a patient is going into a critical form, a shocky form of dengue? Abdominal pain, persistent vomiting, clinical fluid accumulation, effusion or ascites, mucosal bleed, lethargy or restlessness, liver more than 2 cm above the normal. So for adults, this is more than 12 cm. This is for physical examination, 12 cm, more than so it's more than 14. So 12 yung normal, 12 is a normal liver span in physical examination measured via percussion in the lower hemithorax at the level of the mid-clavicular line. So if the liver is more than 14 cm, that is a warning sign. Take note in imaging, the liver span, the normal liver span may be different. For example, ultrasound. So ultrasound, 15.5 cm would be the normal for the liver span. And another warning sign would be the combination of increased hematocrit with decreased platelet. And specifically for children, a warning sign is shortness of breath and abdominal pain. So these warning signs are all correlated or are all explained by the pathophysiology of dengue to affect fluid status and platelets, to destroy platelets. Okay? So, severe dengue at last. In contrast to just dengue with warning signs, severe dengue involves any of the following. So there, severe plasma leakage manifesting as shock or respiratory distress, severe bleed or severe organ impairment, qualifying that as AST or ALT, liver function tests above 1,000, impaired consciousness, and seizures, and myocarditis, and renal failure. So for severe organ impairment, that is organ specific, there is end organ damage because of the severe dengue. Okay, so after the critical phase, we now have the recovery phase. So this occurs over a 2 to 3 day period where there is reabsorption of the leaked fluids and hemodynamic status stabilizes. There is generalized pruritus. This is due to the reabsorption of the leak of fluids. It causes some itching. Herman's rash, the eponymic Herman's rash, described in PE as the Isle of White in a Sea of Red, is due to some erythematous maculopapular or morbilliform lesions. Normalization of the CBC also occurs here. Hematocrit will decrease, WBC will increase. And the inherent risk for the recovery phase is the hypervolemia of the patient because of rapid reabsorption. Hypervolemia, in this case, is made riskier for patients who are admitted because the tendency usually is those patients also will have IV fluids given to them. So fluid therapy. Nag-recovery phase na nga yung pasyente sa dengue, binibigyan mo pa siya ng bags ng IV fluid. Talagang parang nilulunod mo siya. You're drowning the patient in fluids, and this has inherent risks of its own. Hypervolemia. Most notably, hyponatremia, which is a potential side effect of, or a potential adverse complication found in the recovery phase. So as a sort of summary for the course of dengue illness for the natural history, there is this diagram to demonstrate the temporal sequence with which the dengue signs, symptoms, laboratory changes occur. So let's go through each. Let's dissect the diagram one by one, detail by detail. Laser pointer. Days of illness 1 to 10. And here at the bottom, febrile, critical, and recovery phases. So for the febrile phase first, critical phase second, and recovery phase next, as outlined by this dark column block here. So for temperature, obviously in the febrile phase, there is fever. We go up to 40. And this normalizes as the disease process goes on. Okay, so that's maybe one very helpful, one very easy parameter to take note of in the course of dengue illness. Potential clinical issues, the major complications as I've outlined earlier, dehydration, febrile seizures fall under here for febrile phase, shock and bleeding for the critical phase, reabsorption, fluid overload in the recovery phase, probably due to a combination of reabsorption of leak fluids plus fluid therapy. Organ impairment occurs somewhere here, mostly in the critical phase because of increased capillary permeability, because of increased leak of the fluids. There is decreased perfusion to the end organs. Okay? Laboratory changes, these are important. First, hematocrit. There is a spike in the hematocrit at the critical phase. Again, because there is leakage of fluid. The red blood cells are retained in the blood vessel, and this reflects as an increase in the gross percent of the red blood cells in the blood vessel. This increases the hematocrit, therefore. And as the fluid is being reabsorbed, the hematocrit normalizes once again. This is in contrast to platelets. Platelets basically are destroyed in the disease process of dengue. So whenever the dengue disease is most critical, that is when the platelets are at their lowest number here. Critical phase, thrombocytopenia. Serology and virology. Lastly, viremia follows this mound here, wherein the virus load is highest in the serum in the febrile phase, and the IgM, IgG, the antibody markers, are slowly increasing as the disease process occurs throughout the course of the disease. Okay? So, next, for dengue, we also discuss the dengue vaccine, the very controversial dengue vaccine. Dengue vaccine covers all 4 serotypes of dengue. It is a live recombinant tetravalent vaccine. So recombinant vaccine means that generally recombinant vaccines are produced from yeast that has been given some assigned some genes to reproduce the immunogenic components that will induce the immunization in bodies that will receive the vaccine. So that's a rough definition of recombinant. Okay, it is given subcutaneously, it is given in the deltoid area, and it has a 3-dose schedule given at 0, 6, and 12 months. Dengue vaccine is contraindicated, cannot be given for children less than 9 years old, adults older than 45 years old. So the population eligible for dengue vaccine is 9 to 45 years old. Contraindicated, of course, for patients with known allergy, contraindicated for immunocompromised people, and those who are pregnant or breastfeeding. So unfortunately, due to many surrounding controversies, the Dengvaxia brand for dengue vaccine had its FDA approval withdrawn in 2019. So, there is no dengue vaccine being given as of late. I've added this table for your convenience. A common question that may come up is what specific mosquito is the vector of transmission for a given disease. So there are many different diseases brought about by mosquitoes. One of them is the dengue, as we've discussed just now. It can be found here: dengue virus, Aedes aegypti, Aedes albopictus. You can read the others if you want. Screenshot, save it, memorize it. It can be an easy 1 point in either the PrevMed exam, or in the microbiome exam. Even the IM exam. Who knows? Wuchereria bancrofti, Brugia malayi are causative agents of filariasis. So Culex genus, Aedes, Anopheles, and for Brugia, Anopheles, and Mansonia. Plasmodium species. So, Plasmodium falciparum, Plasmodium ovale, Vivax, and Plasmodium noceli. Plasmodium is the causative agent of malaria. Um, there are two species of Anopheles that transmit malaria: Anopheles flavirostris and Anopheles littoralis. Okay? Dengue virus, chikungunya, yellow fever, viral diseases, dengue virus, chikungunya, similar, very similar clinically, as well as Zika virus, although Zika virus has been notorious for some um, congenital diseases. They are both being transmitted by Aedes aegypti and Aedes albopictus. Yellow fever virus, Aedes aegypti, and the encephalitis syndromes, EEQ, EEE, WEE, and St. Louis encephalitis, more in the Western world, Culeceta melanura, Culex tarsalis, Culex tritaenurinchus respectively, and JEV, Japanese encephalitis virus, transmitted by the Culex tritaenurinchus mosquito. So that's the mosquito cheat sheet. Okay? Take note. Probably worth 1 point in the exam. So next we have leprosy. Leprosy caused by Mycobacterium leprae. So there, leprosy, slow-growing intracellular bacillus, infiltrates skin, peripheral nerves, and nasal mucosa. These are the main sites of infection of leprosy. Incubation period takes anywhere between 2 to 10 years. They have a very long incubation period, very long multiplication time. The primary reservoir is infected humans. So it's a human-to-human infection. Significant risk is documented specifically for household contacts of known patients known to have leprosy. Okay? The main, primary, the central symptom for leprosy patients are the skin lesions, peripheral nerve damage, and in severe forms, the anesthesia in the area does not necessarily cause paralysis. There is paralysis, it progresses to paralysis, and because of paralysis and anesthesia, there is physical deformity. And the diagnosis of leprosy involves symptomatic clinical diagnosis of skin lesions, peripheral nerve involvement, and skin smear wherein there are present AFBs, acid-fast bacilli. Similar to TB, for example. The WHO classifies leprosy patients into the following: paucibacillary, single lesion, paucibacillary, and multibacillary based on the number of lesions the patient has. Skin lesions specifically. So if they have 1 skin lesion, that is single lesion. 2 to 5, that is paucibacillary. Pauci meaning konti lang. Multibacillary, 5 or more lesions. This classification is important because the classification will dictate the treatment later on, as we will see. But before we go to the treatment, let's also examine another form or another method, another way of classifying patients with leprosy or who are lepers. This is called the Ridley-Jopling classification. Roughly, it is composed of a spectrum from tuberculoid. Sana yun? Laser pointer. Tuberculoid to lepromatous. So, there is such a thing as tuberculoid leprosy and lepromatous leprosy. I say it's a spectrum because there are actually 5 subtypes: tuberculoid, borderline tuberculoid, borderline lepromatous, lepromatous. Those are basically just overlaps of the two ends of extremes of tuberculoid and lepromatous. Simply speaking, the more benign version of leprosy is the tuberculoid leprosy, and the more toxic version is the lepromatous leprosy. So this table outlines the differences between the two. Just try to imagine and explain each and every one with the idea of the tuberculoid being the more chill, the more relaxed, the more benign version, and lepromatosis being the more toxic, malignant, progressive version. Okay, skin lesions are macular, small, and flat in tuberculoid leprosy, but nodular in lepromatous leprosy. The AFB found in the skin, the acid-fast bacilli, are few in tuberculoid, and in lepromatous abundant. For nerve involvement, the tuberculoid leprosy has severe sudden asymmetric involvement, which means there is this invertedly helps because detection of the disease is faster as opposed to slow, symmetric, but very overwhelming infection, nerve involvement in lepromatous leprosy. The lepromin skin test is positive in the tuberculoid the tuberculoid leprosy, and is negative in the lepromatous leprosy. This is because in patients with tuberculoid leprosy, their cell-mediated immunity is still intact. Whereas for lepromatous leprosy, their cell-mediated immunity is deficient. So it's as if they have also HIV, for example, wherein their immune system is poor. So the skin test will not react negative in lepromatous leprosy because the immune system has already been compromised. So yeah, deficient cell-mediated immunity leads to a negative, a non-reactive skin test. Finally, the skin infiltrates in addition to the AFB in the tuberculoid leprosy will include helper T cells. So helper T cells means there is more active sort of immune process going on, active response to the infection, whereas in the lepromatous version, the skin infiltrates are suppressor T cells already. Okay, so again, it's a spectrum, extremes of tuberculoid and lepromatous, but because there are actually 5 subtypes there, there's just some differences, some overlap between all 5. A possible question that may be asked is, there's a given patient with this clinical syndrome with these following findings. How will you classify them? Are they A, tuberculoid, B, borderline, C, lepromatous? So, yeah, those are the types of questions you might want to study for, prepare for. But for now, it's important to recognize the difference between the two extremes to guide you further later on. So, tuberculoid first, and then lepromatous as two ends of the spectrum. Okay, so now, going back to leprosy, as I've mentioned earlier, WHO classification is based on the number of lesions, single lesion, paucibacillary, multibacillary. This will guide treatment. Paucibacillary single lesion will only involve a one-time dose, a one-time treatment with rifampicin, ofloxacin, and minocycline. So, ROM. Yun lang kailangan mo. Just take these 3 medicines at one time, just for one day, and you're good to go. Paucibacillary single lesion. But, for paucibacillary, which is different from paucibacillary single lesion, you will need a 6-month regimen. That's an upgrade of 6 months worth of daily dapsone and a once a month dose of rifampicin. So DR. Okay? But for multibacillary leprosy, you will need a 12-month regimen of daily dapsone, daily clofazimine, and an additional 1 monthly big dose of clofazimine. So that's effectively 1 big dose and 29 small doses, and an additional once a month dose of rifampicin. So DRC. Um, for some clinical knowledge, leprosy treatment, these drugs will already come in blister packs to guide the patient on which drugs to take at which particular day. So, naka-ready na siya. They just have to follow the tablet for a given day. Parang OCP, parang estrogen, ganun. So, yeah. That's it for leprosy.